Welcome to the Epidemiology Seminar Series. I'm Angela Lee Nguyen, an assistant professor in Department of Epidemiology at Colorado School of Public Health. Today we have Dr. Lori Dean as our speaker. We're truly excited to have her give us her talk on social epidemiology, past, present, and future. Dr. Dean is an assistant professor in epidemiology at Johns Hopkins Bloomberg School of Public Health. She is trained as a social epidemiologist from Harvard School of Public Health. She focuses on how individual and neighborhood level social and economic factors contribute to health disparities and health outcomes for those managing chronic diseases, including cancer and HIV. Today's seminar will be recorded and posted. So please put your questions in the chat box and I'll monitor the chat box and read the questions as received during the Q&A session. So without further ado, please welcome Dr. Dean.
Great. Thanks so much, Dr. Lee Nguyen, for having me, and thank you, Cassandra, for helping to organize everything. I'm excited to be presenting to you today. Today we'll do an intro to social epi, and then at the end I'll talk a little bit about some of the current work I'm doing to help you an idea of the scope. I'll let you know before we start that this talk, I'm still trying to model this on, that's my phone, I should probably make that turn off. So maybe the first thing I should do is remind everybody to turn off their ringers and their sound, because for some reason mine does not want to turn off no matter what I do. Okay, hopefully that should fix it. And then also too that this talk is intended to be somewhat interactive. So I will be posing questions and I do actually want to hear answers. So you can feel free to unmute yourself. I'll also be checking the chat. Try to still model this as somewhat how we would do it if we were in a face-to-face classroom, and think that we can get pretty close to it. So I'm going to start sharing my slides now. We'll get started. I'm going to go here. Let me take this big. Here. Great. And can someone just give me a verbal, I guess, Dr. Lee Nguyen, you can see the big version, right? I just want to make sure you can still see the big version, not the notes version.
Looking good.
Great. Okay. So today I'm going to talk with you about social epi, and the idea here is to give you a sense of how we got to where we are with social epi, a little bit about where we are now, and then where social epi is presumably going. I come at this from the perspective of an epidemiologist, but I'm a social epidemiologist, even though I'm currently in an epidemiology department that spans a lot of different, I would say, clinical and traditional epidemiology. But we'll talk a little bit more about how I fit in and that fits in a second. So what you can expect out of today are a couple of things. One, we're going to talk about what social epidemiology actually is and how that's different from the clinical or traditional epi. We're going to just talk about what are the ways in which these larger macro level social factors contribute to health. And then we're going to talk somewhat about the conceptual frameworks and some current findings, some current research. What I really want to be clear about is you will not be a social epidemiologist at the end of today's talk. No more than if you went to one lecture on cancer, would you be an oncologist? Today, the idea is just to give you a broad overview of the origins of social epi, how it's distinct from some of the ways we've thought about epi in the past, and some of the areas that people like to explore. So the first thing we'll start out with, just kind of what is epidemiology? I believe that everyone in the program is in a department of epidemiology, so hopefully you already know what epidemiology is. But I would describe epi as the study of how diseases are distributed across a population, as well as thinking about what are the factors that influence or determine who gets those diseases, why they get those diseases, and when they get those diseases. That is to say, as Leon Gordis would say, that disease, illness, and health, these are not things that just are randomly popping up in a population. There are risk factors that pattern who gets what diseases, and that we can look at the patterns in those risk factors to determine or to predict who might get those diseases. Social epi is a special carve out of that that thinks about social factors as the risk factors for diseases. So it's a little bit distinct from epi. But let's just start out with epi, and I'm going to ask someone to chime in here. In terms of epi, the birth of modern epi is credited to someone named Jon Snow, right? Not the one of Game of Thrones fame, but Jon Snow, who was a farmer's son and a physician during the cholera epidemic in London in the 1800s. Can someone just chime in and let me know what you remember about Jon Snow, what you've learned about Jon Snow, and what happened in Jon Snow's story?
Hi, Dr. Dean. My name is Michael Gallagher, and I'm a first-year student. So
Thanks.
from what I remember, Jon Snow was able to map out all of the households that had cholera infections, and then through interviewing with, I think there was a pastor that was very involved in the community that he utilized as someone to interview all of the households and see where they get their water from. And then they found that it was this connected to this one well that had supposedly the best water, but it was really the cholera water.
Thank you, Michael. I appreciate that. And I really love that you brought out the part about the well and the pump, because at the time that Jon Snow was doing this work, people believed that that cholera was being spread by what they called miasma. It's actually the word that meant bad air or pollution. They actually thought it was being spread by the air that they breathed, not by the water. And as you explained, that Jon Snow had a different hypothesis behind how all of this worked. Like you said, he did some mapping of all of the water pumps on top of the cholera rates, and then associated those together to really discover that it wasn't miasma that was causing these diseases. It was this pump, this water pump, these contaminated water. So around the time of Jon Snow's observation, people had been writing about all these different types of things, right? And in some way, Jon Snow really rethought how epi was being done, gave a new life to a different type of risk factor. And in this case, it was water, but I would argue that that's exactly what social epi is trying to do with social risk factors. We're trying to reframe what the root causes of what we see as our diseases. At around the same time as Jon Snow, people were starting to think about some of the other social risk factors. So for example, how things like overcrowding and filthy living conditions were associated with things like lower life expectancy. So even beyond something like cholera, considered infectious type of disease, people were thinking about even some of the chronic type of diseases, and people were realizing that these factors were affected by health. So there's someone else in this story that comes right around the time of Jon Snow, but really has not been recognized in terms of their contributions to epi, and particularly social epi, and that's W.E.B. Du Bois. W.E.B. Du Bois was a sociologist. He was the first Black man to earn a doctorate in the United States. Pretty sure he earned his doctorate at Harvard. And wrote an entire series of books on the relationship between the social environment and health outcomes. He particularly wrote a book about social environment and Black mortality in Philadelphia, Pennsylvania, and later presented the findings to the 11th Atlanta University Conference to help move forward essentially what at the time was not called it, but it moved forward a health disparities agenda, even though we weren't using it at that time. But it was mostly focused on sanitation that was in Black communities, because due to segregation and forms of redlining, Black communities were often in communities where water was running downhill, and sanitation and waste was also running downhill in those neighborhoods. So there were heavy sanitation issues. W.B. Du Bois was one of the first people to talk about these social exposures when it comes to health differences or health disparities and inequality, however, has really not been recognized as a hero of social epi. So a colleague of mine and I wrote a paper, the citation is here, you can go and look at it, where we compared what Jon Snow did to W.E.B. Du Bois did, and really shows that as much of Jon Snow is considered the father of epi, we believe that W.E.B. Du Bois should be considered one of the founding fathers of social epi for the work that he did. And there were other people all over the world who were beginning to do some of this work. One of them was Rudolf Virchow. And I'll say that I was, in my undergrad, I did an undergraduate degree called Biological Basis of Behavior. I was at the University of Pennsylvania and did work in, it was a combination of neurology classes, psychology classes, biology classes. And so a lot of these names I had actually heard of from the psychology and sociology classes I had been taking. So it was really neat to see those later integrated into epidemiology and into what I was doing as a scientist. Rudolf Virchow was one of these people. He was a German physician. He did a lot of things, but also an anthropologist and a historian, a biologist, who really felt that we needed to use the combination of the different types of social sciences and biological sciences and bring those together to understand patterns of health and disease. Now, one of the things that's important here is to think about the context. This was right after the Industrial Revolution. So a lot of things were happening. Manufacturing was happening. It was booming. It was really impossible to ignore the influence of the working and factory system on the actual health of the workers. In fact, some of the challenges that were brought up was factory working and how that created poverty and disease. And that's exactly one of the things that Rudolf Virchow investigated and found, that there was this association between poverty and health, something we now talk about in social epi as the socioeconomic gradient of health. That is, that people who are at the worst end of the economic spectrum have poorest health compared to those at the highest end of the economic spectrum having better health. At the time, they felt like things like housing, sanitation, and work conditions were leading to poor health outcomes. But Virchow even expanded beyond that and thought about political conditions, economic conditions, and felt that poverty created disease, and that what was actually needed is that reform or revolution. So even in health, you start seeing these calls for social reform and social revolution, even back in the 1800s, and that we really needed to think our class system and class structure if we were going to resolve persistent health challenges and health problems. That is to say that we needed to start to go beyond the medical and biomedical solutions that we were using to think more about social factors and resolving the underlying social factors that lead to patterns in health. I'd say we're there now. I still think that even now, we still think in a lot of times about health as being in a vacuum, that health is something that should be treated by a physician or in a hospital. But I do think in the more recent years, as more attention has been put on social factors, that people are starting to see that we really need to change the fabric of our social system if we want to preserve our health and resolve and address some of the persistent health challenges that we haven't been able to tackle, especially in the US. The next person who comes in line here to help in terms of thinking about the history of social epi was Emil Durkheim. Durkheim was a French sociologist who studied suicide. And on one hand, while suicide would seem to be an individual act, its etiology actually, Durkheim believed that its etiology really lied in thinking about the social structure and the social context in which people live. And so Durkheim brought together geographic, demographic, psychiatric, several different types of methods to work with data to try to understand what were the root causes, what were the reasons that suicide rates might be different, and were there things in the social structure that would explain why they were different. So Durkheim did some work, and this is data presented directly from Durkheim's work that compared French and German cantons. Cantons is essentially a geographical division. So let's just call them, for example, we'll say neighborhoods. If they could be something, just a geographical division. But started thinking about the religious composition of these geographical divisions, and started looking at differences in suicide rates. So in Durkheim's work, he compared Catholics and Protestants, which at the time were the reigning religions. I believe Durkheim himself was Jewish, but knew that these were the largest populations of types of religions that they had in these places. And as you can see from the slide, if you looked at the Catholic suicide rate in both the French and German cantons, it was about 87 per million. compared to the Protestant suicide rate, which was much, much higher, 326 per million. And if you looked at these areas that were more mixed, it was somewhere in between. So Durkheim saw this as evidence of essentially kind of this graduated response of thinking about the ways in which religion, which could be a form of social organization or social control, might be influencing people's levels of social isolation or lack thereof, and that might lead to greater suicide among some religions than others. It really led him to conclude what you see on the slide, that he felt like Protestantism gives greater freedom to the individual, or has a more focus on the individual, which might lead to greater social isolation, and that might be why there are higher suicide rates in areas that are more highly Protestant, compared to areas which are more Catholic predominant, where Catholicism, he believed, exerted a body of doctrine which was about social integration, and that might be protective of suicide. So we're already starting to see that people are looking beyond what someone's individual religion was. It wasn't about their individual religion. It was something about the religious composition and the social milieu of what was happening in someone's neighborhood and where someone lived that was determining the suicide rate in Durkheim's work. So I'm jumping to 1963, but it's really because there was a person who wrote about a historical figure in 1963 that I think is really instructive and helpful. So in 1963, Saxon Graham wrote about social factors in relation to chronic illness. Saxon Graham was an epidemiologist who spent a lot of time studying chronic disease, studying cancer. At the time, there was a much focus on infectious diseases. But there was in part because vaccines had just started emerging, and so there was a decrease in infectious diseases, which allowed longer life expectancy. So as people began living longer, these other diseases, cancer, cardiovascular disease, chronic diseases started popping up, which caused people to think differently about the causes of diseases, because chronic disease particularly were considered to be multifactorial risk factors, that there were just all types of things that could happen over someone's life that would lead them to having a chronic disease, compared to an infectious disease where in most cases people would say it's this virus or that virus. So the emergence and the emergence of vaccines really is what allowed for or gave rise to what we now call risk factor epidemiology, where we're thinking about the various inputs that could be involved in someone's health. So Saxon Graham basically demonstrated what we say multi-level thinking, and started with integrating sociology with medical sciences and putting together social and biological data to think about the causes of specific diseases, but then also to think about how participation in groups, pattern behaviors, and this chain of events that could be linked to health outcomes. Saxon Graham pointed toward a historical person named Percival Pott, or Percy Pott. And Percy Pott was an English surgeon who did some work looking at scrotal cancer in chimney sweeps. And Percival Pott was actually someone back from the 1700s, but the work of Percival Pott really was reported on by Saxon Graham later on in the 60s. So the Pott really does this work looking at chimney sweeps carcinoma, which is scrotal cancer, essentially scrotal cancer. But I'll ask for you again to unmute yourself. I just wanted you I'll put up some pictures and I want you to comment on what you see in these pictures and what you think about scrotal cancer as a result of these pictures. Percival Pott was looking at the association between soot exposure due to chimney sweeping and elevated incidence of scrotal cancer. So here's some pictures, just take a moment and look at them. All right. Pictures. What do you notice about chimney sweeps from these pictures? And anyone can unmute themselves. And I apologize, I actually can't see the chat box. So if you try to chat, I don't know if I'll be able to see it.
Well, they're very young.
Okay, they're young. Yep. So these are young boys. What else do you see? And wait, why is that an interesting observation? Let's put it that way.
Well, if they're young, then any exposures they're having from a very young age.
I'd also say when we think about cancers, right, we don't necessarily think about, I mean, there are pediatric cancers, but I think a lot of times we think about someone who's had an exposure over time or is a little bit older. So yep, young is interesting here. What else do you see?
It seems like the garbs that they're using aren't very protective in nature. Like they seem very flowy, and like a lot of particulate matter might be able to just move throughout that garb easier. And then also the way that kind of ties into the way that they're standing above the chimney itself, like it's direct exposure to like that area of the chimney sweep.
So kind of that there could be some, well, this was actually the first occupational hazard, the first occupational link, right? They didn't have protective wear or protective gear. And one of the reasons they were young boys is because, as you can see in that picture that you pointed out, they were standing on top because these chimneys are not big. So grown people couldn't fit in chimneys. So it was primarily something done by young boys who didn't have a lot of protective gear. Anything else people notice about this?
It looks like they might be being coerced a bit based on the picture with the gentleman pointing his finger and maybe pulling on an ear.
Yes. So
we'd probably call this abuse today, but.
So this was a dirty job, and it was a dangerous job, and it was essentially a job that young boys from poor or low income families had to do. No one else was doing this dirty job. So they were literally climbing through these hot flues, and they got exposed to soot. They were often, they didn't really get washed. And sometimes, in fact, I think someone said coerced. Sometimes these boys were literally snatched off the streets. They were kidnapped into doing these jobs. So so while on one hand, there was this immediate exposure of this carcinogenic soot from the chimney sweeps, potentially the underlying root cause of this were things like poverty and class inequality that made these boys susceptible to be in that job, and that didn't give them any sort of rights to be able to push back about the health and safety, or for their families to push back on the health and safety of these jobs. What's really neat about this work is that Percival Pott, these observations did lead to some action. It was the Chimney Sweepers Act of 1778, and was one of the first times that people started thinking about occupational exposures. And in fact, as part of social epi, occupational and work exposures is a branch of social epi that many people still study today. So, so this timeline that we've been talking about, right? We've been talking about kind of up through the 1700s, up through the 1800s. Now we're in the 1900s, and things really start accelerating. First, there's the kickoff of social medicine in the UK. In the 1940s, and actually the first time the word social epi was actually used wasn't until around 1956, and it was used in a I believe it was a talk and a paper by Alfred Yankauer. It was a paper on the relationship of fetal and infant mortality on residential segregation. So think about how new the field of social epi is. It didn't even really have a name until the 50s, compared to something like, traditional epi and medicine. So it's a relatively new field. And since then has really grown, and you see in the 60s and 70s, the greater proliferation of work in social epi. Leo Reeder, who was a founding member of the medical sociology section of the American Sociological Association, talked about the study of social factors in the etiology of disease. It was one of the first times that it was really being talked about at a professional society, and was still in the medical sociology, not necessarily in the public health and biomedical context, even at that. So then it starts slowly seeping more into medicine, particularly by the contributions of people like John Castle. John Castle joined faculty at UNC, chaired the Department of Epidemiology in the 50s, and was really focused on the social environment as determinant of health and populations, based on his own work in Evans County in Georgia, using his own county in Evans County, Georgia as a lab, and thinking about health of urban and rural populations. It happened to be a place that kind of formed a natural experiment industrial living. And so it was a way to assess what sort of stress factors might change as someone shifted from rural to urban environments. But it really laid the type of foundation for the things that we look in social epi. And in fact, the framing that we use is often, we think about stressors, these differences in social risk factors as stressors that act on people's health. What Castle argued is he felt like there were these categories or these different classes of environmental factors that could change both, that could change the way, the susceptibility that people felt to the stressors or social factors or risk factors or their environment, and that those produced and involved, they were essentially these environmental conditions, which could be the social or physical environment, to affect our susceptibility and essentially affect who is most likely to be at risk for disease. Again, there's that risk factor epi popping back up again, and essentially said whether individuals developed one disease or another depended on their behavioral or environmental exposures, as well as their biological or genetic makeup. But whether they became ill or died at earlier ages, or whether specific socially defined groups had greater rates of disease, depended on socially stressful conditions. And went on to talk about the context for those stressful conditions, be it nutrition or stress or overwork, psychosocial stress, or social supports or the lack thereof, social isolation, social capital. And that's really where social epi started to branch off from the traditional thinking about traditional epi and even kind of the biomedically faced epi. Nancy Krieger went on to describe social epi as the branch of epi that studies the social distribution and social determinants of health. That's both the specific features of and pathways by which social conditions affect health. So I want to be really clear. It's not just the social factors and how they reflect health. It's also thinking about how they do that, the pathways. We'll talk about pathways in a moment. It's different from clinical epi because whereas clinical epi is really focused oftentimes on just the disease itself, social epi thinks about the social factors, and it says, Krieger would also say, rather than treating those social determinants as mere background to biomedical phenomena. That is to say, when I describe my work as a social epidemiologist, even though I'm jointly appointed in oncology and a lot of my work focuses on cancer and HIV, my actual focus is thinking about these social factors. It's social capital and discrimination, and we'll talk about some of my work in economic factors and how those affect health. Those are my focus, and I don't necessarily see them as background. I see those as part of the primary causes of disease. So people can study a range of things in social epi. Sometimes it's current systems, but it could also be thinking about past systems. So for example, there's an emerging body of work that looks at historical redlining and how that might influence chronic disease and general health outcomes even today. So these might be exposures from many, many years ago, but they still can be believed to have pathways that might still affect us today. It could be material and technological resources. There's a lot of new work that's talking about, the role of thinking about social capital differently now that we have mobile technology, that your social capital might not be, for example, neighborhood-based as we would traditionally think about it, but it could also be based on what sort of access that you have to people on Facebook or Twitter or an online support group, for example. And then it's also thinking it's context specific because it thinks about norms that are within the particular context that you're in, which could also, there are different norms around human rights, there are different norms around standards. So understanding the context of even the country where those social factors and those health outcomes are happening is important. And not just within the countries, but also external political and economic relationships with other countries and how countries interact or intersect. So as we think about how these kind of big level social risk factors might influence our health, I'll bring us back to Rose's strategy of preventive medicine. Preventive medicine. Can someone chime in? Are folks familiar with Jeffrey Rose's work? And if so, could you chime in and help us understand or help remind us?
I can, Dr. Dean. I actually teach some of Rose's stuff. So, Geoffrey Rose was a British physician who was most famous in 1985 for writing a paper called Sick Individuals and Sick Populations. And he talked about a couple things in that paper. He talked about the prevention paradox, which is on the slide, which I know you'll explain, Dr. Dean. And he also talked about a whole population approach that really focusing on policies and interventions at the top level that affect everybody in the society can have a dramatic impact, both in improving overall health and in compressing inequalities.
Good. Thank you. So I don't have a lot more to add. It's essentially what you said. It's that there, as we think about risks for a population, they're distributed across this continuum. He kind of used a bell curve to describe that, and that we were in preventive medicine, we were making this trade-off between helping people at the highest end of that distribution by just treating them, or thinking about shifting that entire distribution so that everyone is less susceptible. And we can help prevent disease in that way. So how does this relate to social epi? Well, Rose also had some perspective on thinking about social risk factors as a way to do that. But that, risk factors predict disease, especially social risk factors particularly predict disease, but they don't necessarily cause disease all of the time, or necessarily predict benefit from an intervention or intervening on them. So inherent in Geoffrey Rose's approach was that social conditions and these social conditions and the social determinants of health. And he actually said that he felt that obstacles to improve health were things like that were economic and industrial and political. And actually, quote word for word, said, socioeconomic deprivation includes a whole constellation of closely interrelated factors: lack of money, overcrowding, substandard housing, living in a poor locality, worse education, unsatisfying work or employment, and reduced social approval and esteem. So Geoffrey Rose was actually talking about these when talking about preventing these challenges. And also to know that risk factors, again, they can predict this disease, but they don't necessarily cause the disease or predict benefit from an intervention. And here I have an example that might help explain this a little bit more. So in the 90s, Hurricane Katrina hit in Louisiana. By FEMA determined that it was the single most catastrophic natural disaster in the United States history. And since then, there's been a lot of work to talk about some of the socioeconomic differences of the damage that was done in particular neighborhoods. So the damage during Hurricane Katrina was disproportionately influenced those who were in poverty. So while poverty was a risk factor, poverty didn't necessarily cause the deaths related to the hurricane, right? It was the hurricane that caused the deaths or the health complications there. And it's not clear if taking people out of poverty would have reduced the health effects of the actual hurricane, right? So that is to say, when we think about social risk factors, we do need to think about assessing risk. And in some cases, the social risk factor itself is what we need to intervene on. And in other cases, we need to think about how the social risk factor patterns that social risk and whether or not we can either prevent it or think about what interventions might be appropriate. So we've been talking about risk factors, and you might think, well, why are we focusing on social risk factors? Aren't risk factors mostly biological? Well, we've known for a while, there's several papers that have been out, but if you look at, for example, human twin studies, right, they suggest that only about 20 to 30% of the variation in survival is to year 85 is determined by genetics. So it's not entirely biological or genetic. And then others had estimated that medical care was responsible for only about 10 to 15% of preventable mortality. However, when you look at major health behaviors and health inequality, that accounts for about 20% more of people's health. So that is to say that in thinking about social factors and thinking about that 20%, tackling social factors and thinking about the role of social factors might help us more than just providing medical care. We still need to provide medical care. That needs to happen equitably across the population. But it might be just as important as thinking about the genetic factors that, in my opinion, seem to get so much more emphasis than the social factors that we can really tackle with more political will. Okay. So we've been talking about kind of what causes disease. Well, where do we look for causes of disease? And I would say that would depend, terms of social epi on where you are in time. We talked a little bit earlier about the contributions of Virchow. There is also Vierme in France, who also talked about the association between urban conditions, like things like poverty and occupation and health outcomes. But actually, for a long time, this idea of miasma that we talked about with Jon Snow still really reigned. And miasma started focusing on the, unsanitary conditions. And then over time, people started thinking about, in the 1850s to 1900s, it moved to thinking about germ theory. And that is that disease was seen as something that was still focused at the individual level. It was focused on an individual being susceptible to a germ, or honestly, sometimes a gene, and still little attention was being paid to the social context. Then by about the 1920s, germ theory had been expanded to consider the interaction between germs and environmental conditions. And then over time, we started talking about the gene and environment conditions. However, that still doesn't get us as far as we need to go necessarily, because as Anthony McMichael would say, for so long we've been prisoners of the proximate. That so much of the work that we think about is about the most proximal causes, the ones that are close to the individual, the ones that we feel like we can most easily measure, the ones that are under individual control. But that really reflects just a Western set of values and beliefs. It presumes that we have the control over all of our health outcomes, and we have these values to do, when we might not always, and where the context in terms of what we do, well, the health behaviors that we engage are actually determined by our context. So the literature is just full of evidence on the connection between social conditions and morbidity and mortality, but yet many times the focus is still on those proximate causes, and really focus on the individual as opposed to these larger social and macro distal causes that require us to look, what people would call look upstream. That is to consider looking and considering the manifestation of disease from the population level, and that it represents more than the sum of the individuals. That there are things that even just being a part of a population confers in terms of susceptibility to health or susceptibility to disease. And Paula Braveman has developed a nice graphic to show this, these upstream and downstream determinants of health. It's this idea that there's our individual health, but our individual health is embedded both in medical care and personal behavior, but outside of that, that is embedded in a context of living and working conditions and economic and social opportunities. And I think one recent example is from Flint, Michigan. Maybe someone can unmute themselves and just share about Flint, Michigan, what happened there, what you remember.
From what I remember, sorry, it's Michael again. But from what I remember is, I think it's been happening for almost 7 years to a decade. Flint's water supply has been pretty contaminated, just all around. The water is actually displayed on the screen. There's been a lot of, I've at least seen a lot of information on social media trying to bring awareness to it, but unfortunately there hasn't been political movement to actually address this issue, even though it would be fairly straightforward to fix.
So yeah, the Flint water supply for a while has been linked to poor cognitive outcomes among the youth there, and it's been known for a while. I mean, in fact, it had been known for so long that private companies and private entities were outsourcing their water from sources they knew that were pure, while city residents continued to have to drink, a contaminated water supply. While the initial blame was, put on the city officials for this, who do share in the blame. If you look at the entire context of thinking about the way city funding was working and these other things, there's a lot more to the story, and really points us to thinking about, even though the initial and the most proximate cause was something happening in the water supply. If we looked more upstream, we realized that we needed to deal with corruption and other challenges that were outside of health. We were really going to fix the water supply happening. And as I think, as Michael was saying, these problems still aren't fixed. It is actually still ongoing because we haven't fixed the root causes of this issue yet. All right, I'm gonna keep moving because I got more to go and I wanna make sure I get through these things. So as we think about this, thinking about these upstream approaches, we wanna think about social and structural conditions and how those shape our access to social networks and how that then relates to psychosocially, how we respond to these environmental stimuli, and that helps us think through the pathways. So that is to say, if you wanted to think about how these big factors get embedded or embodied in people's health, you need to think through all of these different levels. And social epi is explicit about levels and multi-level thinking. So we've talked about what the factors are, what type of factors you'll see. Well, when are these social factors important? So that's another part of social epi that crosses over into life course. So there are different ways in which we believe that social factors might be important. And this is not all of the ways, this is just 3 of the ways that are in one of the life course models where we talk about different types of effects or different times in which social factors might influence your health. One is called latent effects. That is when something about the early environment affects your later health outcomes. And that is to say, some people would talk about something like critical periods versus sensitive periods. So a critical period, for example, is a time period in which you can have an exposure, however, and then it leads to a health outcome. Outside of that developmental window, there's no excess disease risk associated with that exposure. So that is to say, it's a critical period because if the exposure is happening at a specific time, you'll get a specific health outcome. But if it happens outside of that time, you don't get that health outcome. A sensitive period is a graduated version of this, whereas you can have an exposure at one time, and then if you have it outside of that period, there still might be some influence of that same exposure later on, but it just won't be as strong. So one example might be lead exposure has negative effects on cognition throughout early childhood, but it's potentially between the ages of 1 and 3 is when lead exposure is the most harmful. And then outside of 1 and 3, lead exposure is still harmful, but not as harmful or detrimental as when you have it at these young ages. So we're going to do a little bit of a test, mostly because I just want to show pictures of my cats and my COVID kitten. This is James Bond. It says Othello, but the Othello is actually our other cat. This is James Bond and our COVID kitten, Hannibal Shenanigans. So I'll tell you a story, and what I want you to tell me is what type of latent effect it is from the last slide. So if you cover a kitten's eye, that is my Hannibal Shenanigans on your right side, if you cover a kitten's eye at a particular time, the visual cortex won't develop, and the kitten will be blind always in that eye, despite the fact that the kitten can otherwise see. But if I were to cover Hannibal Shenanigans' eye now, nothing would happen to me. Nothing would happen to the cat, sorry, nothing would happen in terms of the cat's vision. So out of the type of effects, can someone chime in and tell me what type of effect you think that would be?
Critical.
Excellent, excellent. Yep, if you guess critical period, that's exactly right. So that's just that's a biological example of how we think critical periods could act. But we also do believe that we could apply these in social factors. And we see this with some of the larger experiments, like the moving to opportunity. We see that the effects of poverty are particularly challenging when people are very young compared to when they're older. So we know that these things happen as well. But we also, when we think about social epi and social risk factors, thinking about the when is important in terms of thinking about the what. So where are we so far? So in terms of social factors getting under the skin, this is what we call embodiment. The idea that bodies biologically are expressing the larger upstream social conditions that they experience. This happens over the life course, though again, when in the life course matters in terms of when they're expressed. And we believe that that could also point to various pathways. Those could be biochemical processes, they might be candidate systems or stress systems that might be affected. Okay, and actually I just said this, so I'm going to skip that. So we see this happening in one of four ways. One of four ways that upstream factors can influence health. One, it could be reducing or producing stress for coping strategies. It could be shaping social norms through people and environmental cues. So for example, we look at mutual trust is linked to lower homicide rates. Or thinking about something like the social acceptability of gun ownership and how gun ownership is associated with higher gun violence and suicide rates. Right, those are social norms that might be different across countries. It might also, upstream factors might enforce patterns of social control. So, is it okay to take a break during lunch? Is it okay to work fewer hours during COVID? Is it okay to leave at 3 p.m., right? What are these social control mechanisms and how are they interacting with people's health? And then there's environmental opportunities, right? There's physical conditions that lead to poor ventilation, for example, if you're at a hazardous workplace or hazardous chemical exposure. But also we use that example of the Flint, Michigan water, right? Flint is one of the poorest cities and is next to a General Motors plant. And the General Motors plant could afford to get clean water from other sources, whereas the people in Flint could not. So again, the social environment was impacting the people's health in different ways. It's important to remember too that as we think about social factors, right, they might be health promoting, but they could also be health damaging. So we don't want to label some social factors as only good or only bad. They can generally work in either way. Okay. So just a couple examples. Actually, okay, I think we're running out of time, so I'm just going to skip a couple of these. And just to point out that on one hand, all behavior has a social context. If we think about drinking, there's a social context of why people drink and when people drink and how much it's okay to drink. But then also one of the jobs that I had done before coming into academia was I ran a $13 million tobacco control program. And I noticed that there were a lot of messages about that normalize smoking. It could be parents, it could be celebrities, or even the fact that we tell kids not to smoke, but then when they go into the store, the displays for tobacco products look a lot like candy. But what that helps us to think about, again, is context. And there are some methods that social epidemiologists use. One is MultiLevel Analysis. And that is a way to think about and to capture the impact of things happening at various levels from the neighborhood level to the individual level, and looking at how much each of factors at each of those levels contribute. Or sometimes it's something in the middle. So for example, this is some work I had done looking at neighborhood consumer credit scores and risk behaviors. So the idea is that your neighborhood that you live in actually has a credit score, somewhat based on the aggregate of what the credit scores of the people in your neighborhood are. But my study was one of the first studies, was the first study to look at the relationship between consumer credit and chronic disease at neighborhood levels. So this was a neighborhood level consumer credit and an individual level chronic disease, and showed that for every 50-point FICO score increase or credit score increase in your neighborhood, you were less likely to have a chronic disease. But multi-level thinking can also help us think through things like discrimination. So Kamara Jones and others have talked about racism and discrimination as a public health problem. And we know that when we think about racism and discrimination, it doesn't happen just at one level. There's internalized discrimination could happen within us, interpersonal discrimination, which happens between people, but then there are also higher forms of discrimination, institutional, that could be things like residential segregation or housing policies, and then structural segregation, which is the totality of all of those systems. And in fact, a recent doctoral student of mine just recently published the first measure in the health literature on structural racism. That's a paper by Jeff Doherty, in case anyone's interested. But then sometimes we only think about things at the neighborhood level altogether, and we use ecological study design and ecological measures. That is to say, we might be only looking at something at the area level. Ecological measures might be the density of grocery stores or parks or voter turnout or something happening at the neighborhood level. We can't necessarily draw individual inferences from ecological levels, but it can give us a sense of kind of what the social context is in which people are engaging in behaviors. So where does social epi go next? Sandro Galeo a couple of years ago wrote a paper about social epi and the 6 paths essentially for social epi and where we need to go next. We've done a lot to elucidate the types of social factors that are important to understand health, but we don't always have a full grasp of mechanisms. We need to better embed inequality and disparities into the work that we do. We also need to think about thinking about new methods. So for example, the traditional epi is built on methods where there's an exposure that can be easily put in and taken away. It's based on things like vaccines where you either have it or you don't. But when we think about a social factor like poverty, right, it's not so easy to just put poverty in and extract it and understand what those influences would be. Or racism, right? When these things are pervasive all around us and embedded in our systems, we need new methods to really understand and model the influence of these factors. We also need to take our work in social epi and think about how do we have interventions? How do we actually change some of these things and see what the concomitant change in health would be? But then we also need to bolster the theory and the population health work and the impacts that we have of this work. So I hope you've gotten taken away from today that social epi, it's a relatively new field, that the roots of that really considers that the social roots of diseases are upstream factors and thinking about things over the life course that get biologically embedded over time. And that these factors can influence health both directly and indirectly through behaviors, through social norms, and through psychological and physiologic responses to the world. And today was just, again, it was the amuse-bouche, we'll say, of trying to understand a very large field. If you'd like to learn more, there are a couple of opportunities. Hopkins has a summer institute social epi course. It should be opening for enrollment. I teach one of the courses. It would be an expansion of this course of Foundations of Social Epi, where this is largely part of the first lecture for that summer course. And then Manuel Franco teaches topics in social epi, which I think is more looking at various papers and emerging findings in social epi. So you're welcome. I'd love to see you in class for that. And other than that, if you want to reach me, you can find me on Twitter. You can also check out some of the projects that I'm working on, or you can email me to talk more. I'm going to end this slideshow. Hopefully we have a couple of moments for questions, but thank you for your time. Oh gosh, I apologize, Dr. Lewin. That went even longer than I expected. Now I realize we have like 6 minutes for questions.
No, that was wonderful. I don't see any questions in the chat box, but please feel free to unmute yourself and ask any questions you may have.
So I have a quick question. It's kind of more overarching. And I was looking at the dates and kind of the language that these folks that were kind of the founders of social epidemiology, and I was like interested in seeing how like dialectical analysis and I think it was like Marxist theory influenced the like social epidemiology language in the sense that I guess society is based on the structure, or the structure kind of defines what happens within the society. I think I'm not saying my question as eloquently as I would like to, but I'm not sure if you knew of any kind of influences like that.
So I was going to say, I think that more than Marx, that Max Weber was more influential in the way that we currently think about social epi. And in fact, there's a great chapter on this that I might be able to send you that talks about kind of the Marxian versus Weberian perspectives, right? But especially in terms of the way that we think about the social production of disease and potentially the ways in which we think about the socioeconomic gradient of health, that is thinking about things like income, education, right? They're very much based on productivity, and they're also somewhat based on sad to say, the exploitation of certain classes over others, right? That's how we explain things like the socioeconomic gradient of health. So not to say that there aren't influences from Marx, but in terms of the way in which the field has developed, much more influenced by Weber, yeah. Social epidemiology, the Berkman, Kawachi, social epidemiology, I want to say it's like chapter 1 or 2, and it's in my office, so I can't even pull it down for you. Has some great chapters on that I would point you to for that.
Thank you so much. Yeah, I will look that up definitely. I appreciate it.
Mm-hmm. Sure. All right, and it looks like there's one from Jax. Jax, do you want to unmute or just read it on off the chat?
Hi, my name's Jackie. My baby was crying. That's why I did it in the chat. First of all, thank you so much for your lecture. It was very informative. Second, do you have any advice for how to best communicate these concepts of how important social factors are to our elected leaders and policy decision makers?
So I confronted this a lot. So as I mentioned, before coming to academia, I ran Philadelphia's tobacco control program. It was like this $13 million program that was responsible to do policy programs, work with the mayor, work with the city council. And there were a couple of things I learned from that work. One, if you're going to speak with policymakers, speak locally. That is to say, unless I was showing up with something with, like, for example, the poverty statistics on the poverty and mortality statistics on their council district, they weren't listening, right? Because they were really concerned about with their own domain. And they were really concerned too about, will people vote for me if I care about this issue? So I think to the extent that you can connect it to public opinion or things that people say are important, and how much does this cost? So some of my work has moved into actually thinking about doing more cost analysis, because it will take, in some cases, additional resources to resolve these issues, especially if we're thinking about deep-seated, rooted systemic issues. I'd also say too that I found that public health solutions to public health problems are not always public health solution. So don't be afraid to think about what I would call some strange bedfellows. And I'll give you a concrete example of this. We were trying to move forward some tobacco control work that would reduce smoking advertising. One of the ways that a more succinct example, just because that's a long story, a more succinct example is we wanted to increase tobacco taxes. And we also knew that the city of Philadelphia needed money for its schools. So we decided to talk with the education people and say, if you can help us push this forward, we'll turn over this money so that you can, for school funding. And there were several examples where we worked with zoning, or we worked with law enforcement, or we worked with other people. So I think also kind of having other people in your corner that say, hey, yeah, this is going to promote health, but it's also going to help in these other areas could really help. Okay, I think there's a question from Isaac, and I'm sorry, I actually have a hard stop at 3. I have another meeting to get to, but I'm going to try to answer your question really quickly. Isaac says, from the perspective of a social epidemiologist, what are some of the most important relationships between social factors and health outcomes that COVID-19 has uncovered or highlighted? So I would actually say, from my perspective, it actually hasn't uncovered everything. We already knew that this was going to happen. We already knew who was going to be most affected. We'd been studying these for years. What I would say, and something I've said from the beginning, though, I think it also challenged us to be more complex in our thinking. So on one hand, while everyone was saying, this is definitely going to hurt Black and Latinx communities the most, I think the other message that we needed to be sending is, this is going to hurt people who are in jobs that don't have the luxury of taking time off, or this is going to hurt people in the service industry. This is going to hurt blue collar jobs the most. So I think I would hope that it's helped us to actually expand who we think about in terms of who is underserved, that, racial disparities are present, they're there, they're important. And we also need to think about the complex intersection of race, class, employment, and these other factors. That's really, I think, the only way we can tell the whole story behind COVID and what happened and to which populations. Okay, thank you so much for this opportunity. Please feel free to reach out to me. I would love to see you in the summer courses if you have an opportunity to do it. And all the best to you as you finish out your 2020. Thanks again, Cassandra and Dr. Lee Nguyen.
Thank you so much, Dr.